I would like to welcome Dr. Kim and thank her for coming today. And we have everybody on mute right now. However, you can either type a question into the chat box, or you could unmute yourself and ask the questions. As Carrie said that she's willing to accept questions throughout the presentation as well. So if you want to hang on at the end of the program, I have a couple of little announcements, and I'll give the floor to Dr. Kim. There you go.
All right, thank you for the introduction. And I'm excited to be able to have the opportunity to talk about our Mindful Teen program. It's something that is really quite important to my professional identity, and I love talking about it. So please, as Jeanette mentioned, stop me if there are any questions along the way, because I want to make sure that we're being clear in presenting who we serve and what it is that we're doing. Let me just get on the slides here. All right, so just to give a quick overview of what we're going to try and accomplish today. One, I just want to touch on who it is that is requesting services through the Mindful Teen program. I'll paint that picture a little bit in terms of who our clientele are, the families that we're working with. Also to talk a little bit about the DBT, dialectical behavior therapy for adolescent treatment model that guides the Mindful Teen program. And then also just talking a little more in detail about what it is, the services that we offer, but also just giving a brief introduction to some of the data that we're collecting as part of the program and the clinical work that we're doing. There's a lot of information on this slide, and I in part did this because when we're talking about adolescent suicide, there's a lot to consider. And so we know that despite all of the ongoing policy and clinical and research efforts that have been made over the past few decades, that unfortunately the rate of suicide is actually increasing over the past decade. It shifted from being the third leading cause of death among our adolescents and young adults to now the second. And I start with this because many of the teens, if not all, who are presenting to us have some form of suicidality. It may be that they have had past suicide attempts, oftentimes multiple, and it's also not uncharacteristic that they're also experiencing ongoing and pretty chronic suicidal ideation, whether or not they've acted upon these thoughts. So I just wanted to paint a picture in that regard. Nationwide, we know that 16% of high school students who were sampled randomly and representatively have seriously considered suicide within the past 12 months. This is according to the Youth Risk Behavior Surveillance Survey. And then on to moving forward, 7.4% of them have actually made an attempt in the past 12 months. So this is a rampant epidemic amongst our youth that we really need to get a hold on. We know that female students are twice as likely to have made an attempt, that Black students have reported the highest attempt rate among the sample of adolescents that were surveyed. We also know from another source that LGBTQ youth are 2 to 4 times more likely to make a lifetime suicide attempt. And scary enough, all that is, but up to 11% of those adolescents who make an attempt will eventually die by suicide. And perhaps even more scary, putting on my hat as a clinician, but up to 77% of the adolescents who make an attempt either don't ever attend or they do not complete the treatment that is known to be of best efficacy for them. Now we know that, as was reported in the news, I think just a few months ago, Rhode Island was actually ranked for the past 2 years the quote unquote healthiest state in the nation. And this is in regards to teen suicide. And there's still a lot of work that we within Rhode Island need to do because it continues to also be similar to nationwide, the second leading cause of death among our adolescents and our young adults. And representation-wise, numbers look pretty similar to the ones on the previous slide, with about 16% of students reporting seriously considering suicide and about just shy of 11% having made an attempt. Now, within the Mindful Teen program, as I mentioned, we certainly work with a predominance of folks who are presenting with suicidal ideation and or behaviors. What we're also seeing are youth presenting with non-suicidal self-injury, so any intention or intentional form of self-injury, however, without the intent to die. And it could be for many different purposes, and I'm happy to speak on that a little bit more if there are any questions. We are also looking at a population of youth who are either at risk for needing higher levels of care or have actually had recurring admissions to higher levels, meaning anything above outpatient level of care, whether that's in-home services, partial program hospitalizations, inpatient psychiatry admissions, residential treatment facilities. So anything above that outpatient level of care. In fact, I can remember at least one youth who sticks out quite vividly in my mind, that when they came to us, they had had 19 inpatient admissions within the past 12 months, which is overwhelming for anybody. Diagnostically, we're seeing quite a range. However, probably the most prominent disorder that we're working with is major depression, but we're also seeing lots of generalized and social anxiety, obsessive compulsive disorder, and I think the thread that kind of pieces all of these diagnoses together that makes our program perhaps a good fit for the teens that we're working with is this concept of emotion dysregulation. So it's not necessarily the particular cluster of symptoms that they have, but it's this underlying difficulty to manage and regulate their emotions within multiple contexts. And in addition, we see kids who are struggling kind of across the board. So whether that's within their peer circles, their family systems, academically, and so it's not uncommon that we see kids who are struggling in multiple of these domains. And I had mentioned that DBT is the framework within which we function. And DBT, so dialectical behavior therapy, is a psychotherapy that has existed for quite some time, since the late 70s, early 1980s, and it was developed, excuse me, by Dr. Marcia Linehan, who at the time was working with patients who were adults presenting with chronic suicide and self-harm. And after multiple attempts of trying to work with them from more of a standard cognitive behavioral therapy lens, which really focuses and pushes kind of towards change and trying to modify behaviors and thoughts, she quickly learned that pushing heavily on the change aspect was not effective for this particular population, as it was really quite invalidating to the experience. And so then she flip-flopped to the other side and looked for more of a radical acceptance-based approach. And that also wasn't necessarily the most effective to have solely an acceptance-based approach. And so what she did was take cognitive behavioral therapy with more Eastern kind of Zen mindfulness practices that preached more of an acceptance base and merged them together. And so DBT is a comprehensive multimodal, which I'll talk a little bit in regards to the Mindful Teen program. It's manualized, which I think is useful for kind of disseminating what the treatment is, and yet it's principle driven, so that it doesn't have to be very cookie cutter, same session by session. It's really driven towards what's most effective and best for the patient sitting across from us. There's a ton of data about DBT, particularly with adults, and so we just know that what it was that Dr. Linehan was trying to reduce was, in fact, it was happening with DBT. So we were seeing decrease in borderline personality disorder symptoms, depression symptoms, suicidal ideation and behaviors, decreased non-suicidal self-injury, which the most common form of is cutting. But we also saw, and this is even more promising for the treatment model, that there was decreased service utilization. So there were fewer inpatient days spent inpatient visits to the emergency room for safety or psychiatric concerns. There was improved treatment retention and just in general, more of an improved interpersonal and global functioning. What ended up happening towards the end of the 1990s is that we had a whole lot of kids who were struggling with suicidal thoughts and behaviors, and we did not have a treatment known to be effective for working with them. And so Drs. Alec Miller and Jill Rassis, who had trained with Dr. Linehan, adapted the DBT model for adolescents. So you'll notice in some of my slides I have DBT-A. So this is specific to adolescents and their families. And they did this not necessarily with the research yet out there supporting it. And so what they did, they took the DBT model and they just downward extended it and made some modifications. So they shortened the duration. Typically, DBT for adults at minimum is a year of a commitment, and they modified this to be a 6-month commitment. They added in a skills module. So instead of having 4, there were now 5. And then they added in families, because of course, if you're dealing with adolescents and teens, that's a necessity. That's an essential ingredient. That being said, so they've made all of these changes to a model that we knew worked for adults, and then kind of in reverse, our field kind of did the best they can to research and to make sure that we were in fact serving the kids that we wanted to serve effectively. And so there's been, again, now more of a growing body of literature out there for DBT-A. And in fact, instead of going through all of this, I'll just point out that we know that DBT-A is effective and helpful for multiple diagnostic groups. We know that it's useful in multiple settings, whether it's residential or inpatient or partial programs, even some within correctional facilities, and more broadly within schools, in more of a preventative approach. It was just 2 years ago now where the first study was published that bumped DBT-A into the domain of being the first well-established evidence-based treatment that we have within psychotherapy, specifically to decrease suicide and self-harm behaviors among adolescents. Now, just to bounce back a second, that's not to say other treatments aren't necessarily effective. So cognitive behavioral therapy is an effective treatment, and it's just not had enough of studies kind of showing the same results over time. So we just are growing the field as we go along. So I mentioned earlier that the model that Dr. Linehan created was based off of trial and error, basically, of working with adolescents who were presenting with chronic suicide and learning what was working and what was not. And so this just points out that change as the sole focus wasn't necessarily effective. Completely accepting circumstances was also not necessarily effective. And so it was a synthesis, this idea that dialectics, two things that are seemingly opposite from one another, acceptance versus trying to change what's going on, loving and hating, any of those really extremes, black or white type of thinking, that it can in fact coexist, that there's a lot of kind of gray and complexity in between. And the concept of dialectics pushes us to think that there is not necessarily one absolute truth, that, for example, in an interaction between two people, there's my truth, the other person's truth, and then there's a lot of context within the middle. So some of the things that we talk about, the dialectics that we focus on within DBT with our mindful teen kiddos, is looking, you didn't necessarily create all the problems that you have right now, and you have to take charge of working to make them better. And other common thoughts are, you as a parent are tough and you are gentle. That, again, you can have multiple ways of being and functioning depending on the context and who you're interacting with. There we go. All right, so within DBT generally, but also more specifically to DBTA with adolescents. We have individual therapy that we're seeing our patients at least once, sometimes more than that, per week for a one-on-one session. We're also having them attend a multi-family skills group. And again, I'll talk a little bit about what this looks like within Mindful Teen in just a moment. There's also 24/7 phone coaching, meaning that the teen and the parent can access their clinicians for kind of generalization of skills and crisis prevention, so that folks are not needing to go to the emergency room, that they're not needing to go to the inpatient facilities if we can kind of work with them through those moments. There's also case management and family therapy, and then at kind of the crux of the treatment, we have a consultation team. So each of these modes has a particular function. So for instance, with the skills group, the idea is that that's where we're packing in knowledge of the skills that we're going to teach within the DBT model. That's where they're getting the information. Individual therapy is a place in which we can try to pull those skills out of the person once they've learned them and figure out, okay, how do we build this into your life? How do we personalize this? The coaching, the phone coaching has a similar function in that it's a way in which we can pull the skills out of the person and have them practicing it in their real world. And the consultation team is really to make sure that we're doing the best that we can to treat our families who are struggling and with some really high risk behaviors at hand. The team piece is also not only to help make sure we're doing the treatment effectively, but it's also to keep the clinicians supported and motivated moving forward, because it's hard working with kids whose lives are at risk, and it can be really quite stressful, and it can lead to burnout quite quickly. So that team is intended to address all of those issues simultaneously. Now, DBT is not necessarily a suicide prevention program. In fact, it is a program in which the ultimate goal is to help a person build a life worth living, meaning that they have resulted in using suicidal behavior, non-suicidal self-injury, and all these other maladaptive behaviors as a way to respond or react to their emotions, to manage in the moment ineffectively, and yet manage in the moment. And so we're giving them the skills within this treatment model so that they can more effectively address each of these instances and then move forward so that they're motivated, they're committed to staying alive. Within the DBT treatment model, we take a little bit of a different approach, I think. So I actually was initially trained more as a cognitive behavioral therapist. And it was really upon coming to Bradley and kind of expanding my skill set that I was involved with DBT specifically. But when I look at this, and this is how we kind of guide what happens within the treatment, my belief and what I typically say to families as I'm working with them is that psychotherapy, in our more traditional popular view of what that is, what therapy is, starts here at target 3. So we're addressing things at that point that are quality of life interfering. That could include depression symptoms, anxiety, peer conflict, family conflict, substance use, things that are, presenting in the moment within our offices, the reason for which families are often seeking services. In DBT, we do that, and before we really dig into each of those issues, each of those quality of life interfering behaviors, we really quite pointedly and directly and repeatedly address target 1 and target 2, which are life-threatening behaviors and treatment interfering behaviors. So anything under target 1 would include suicidal thoughts, suicidal behaviors, NSSI, anything that can potentially put their life at risk. And we kind of give the explanation of, if we can't have you stable enough to stay alive, the purpose of targeting or getting into the meat of target 3 is kind of not necessary. We have to make sure you're going to stay alive in order to continue doing the rest of the work that needs to get done. And target 2, the treatment interfering behaviors, this is where we're really pointedly, again, talking about things that are getting in the way of either that person or us as a team, a pair of equals kind of working with one another and getting the work done, whether that's coming late to sessions or not completing assignments, or in reverse, it doesn't necessarily have to be the patient that has a treatment interfering behavior, but also the clinician can be kind of in that role. And so we address that because the relational piece is absolutely necessary to not only make sure that we're keeping target 1s under control, but also to move forward and get this target 3 and 4 work accomplished.
Carrie, we have one question.
Yeah.
Someone was asking if any of this research or data has been shown or done with pregnant teens as well as non-pregnant teens.
That's a great question. You know, there's nothing jumping out in my mind right now where we're talking specifically about pregnant teens. That's a great question. I'm not sure that that exists.
So they could actually be included in some of this data without being designated as such. Is that possible?
Correct. Right. So there are actually quite a few studies, unfortunately, that some of those nitpicky details of who they're working with aren't always kind of presented. And so there are some question marks. It could be that there are teens participating who are pregnant, and I don't know of any studies out there, certainly where there's a group of pregnant teens being provided the treatment as like a targeted population.
Thank you.
Yeah, absolutely.
I just want to add to that. Is there a possibility that pregnancy could be one of the reasons for suicide?
I think that it could certainly add to the risk given circumstances of, you know, how the pregnancy came to be, whether it was trauma related or, you know, I can imagine that just adds a layer of complexity.
Right.
For sure. Yeah. So increasing the risk of suicide, you know, a teen perhaps not knowing where they can go or if they have supports and not knowing how to handle the situation. I could see that fueling the fire.
Yeah. Let's get a study started.
Yeah, absolutely.
Thank you.
You'll see at the end of this, there's a lot of kind of directions my brain goes in when I think about the kids that we work with. So I appreciate you bringing that up. All right, so I mentioned earlier that there's the multifamily skills group. It's a training group, and when I'm meeting with a family for the first time, I often describe to them that it's truly more like a class than a traditional group therapy setting, what we might think of. Oftentimes, I think in more popular shows and conversations, we imagine that a group therapy is very process-oriented. We're talking about the details of our own personal experiences. And within DBT, there's a little room for that, and it's all within the context of learning these skills. And there are 5 modules that I mentioned for DBT-A specifically. So we have mindfulness, and this is really seen as the core skill, and it's taught repeatedly throughout a cycle of the 6 months that the patients are in treatment. And the idea is that in order to use any of the other skills, we have to be attending to what's going on in the moment. We have to be kind of in tune right there in the moment in order to know what do we need and what do we need to do. The other skills modules that are presented focus on emotion regulation, so learning skills, things that we can do to manage our mood, and perhaps more in a preventative way, as opposed to addressing it in a crisis. So it's focusing on things like our sleep and our eating and our exercise, and making sure that we're doing things that help us feel like we're mastering a task or confident in our capability to do tasks. Distress tolerance is another one, and this is more, in my mind, a kind of a counterpart to emotion regulation. similar types of skills, and yet it's more in the moment. I'm starting to have a crisis build up. What do I need to do in order to get through this without trying to take my life or trying to hurt myself, doing something that's going to kind of spiral it further down. We also have skills that are very focused on interpersonal effectiveness, and in my mind, even relatedly, this walking the middle path kind of stretches that interpersonal effectiveness. Within interpersonal effectiveness, or IE, we talk about how you can interact with really just about anybody to get your goals met, your needs met, the other person's met, and have relationships that are quality and important. Walking the middle path is specific to adolescent and parent conflicts and issues that may arise. So it's very much targeted towards the family system, whatever that system happens to look like. So let me just jump a little bit into Mindful Teen. We've been in existence for, in some fashion, about the past 8 years. Initially, it started when the outpatient department was getting just constant referrals for youth, for adolescents specifically, who were struggling with suicidal thoughts and behaviors and other emotion dysregulation difficulties. And at that point, what we were able to provide was a DBT-informed teens-only skills group. And so families were not involved. There was no consultation team, and there was no, not necessarily a tie between the skills participation and individual therapy. So it was just the group. And it grew from there. In 2014, our team of clinicians, at that time it was about 10 of us, went over the span of 6+ months, 1 week, and then 6 months later, another week, to an intensive training with kind of the powers that be that teach nationally the DBT model. And it was after that, really towards like the beginning of January 2016, more specifically, where we then shifted over to more of a full model DBTA program, meaning that we were the hub for all of the DBTA patients that we were working with. So if a kiddo was coming to us and they wanted the skills training group, they would also come to us for individual therapy and phone coaching, and we had our consultation team running consistently at that point. The last little bullet point on here references our partnership with the Compass Lincoln House DBTA residential program that is still ongoing at this point. All right, so who is it that we're working with? We are working, generally speaking, with teens who are between the ages of 13 to 18. These teens are in 8th grade all the way through high school. They're presenting, as I had mentioned, with a range of suicidal, or as I have abbreviated here, SA, suicidal behavior, non-suicidal self-behavior, and other risky behaviors, whether that's disordered eating or running away or substance use. We have quite the range. However, the suicide and NSSI are by far our most prominent behaviors. I mentioned that these are kids who are coming to us because they're at risk for higher levels of care. They've tried really a gamut of things by the time they've landed with us. We focus on an explicit commitment to staying alive, and this is a big one that we work with families to assess and establish before truly giving the green light for them to join the program. The team and family have to be ready for all the work that's going to be thrown at them, because DBTA it's a heavy commitment in order to complete the program and have the person want to be able to stay alive is a big piece of this. And so that's where we kind of focus on the commitment of the caregiver to engage with the teen in the treatment. If a teen unfortunately comes to us and they don't have a support system, we don't typically take them within the program. That being said, we have made some modifications over time. So I mentioned the partnership we have with Compass Lincoln House, and currently we have one multifamily skills group focused solely for the outpatients that are referred to us. They can come from truly any referral source, but oftentimes from inpatient and higher levels of care. We have a second group that is dedicated just to the residents of the Lincoln House program. And those girls, so it's a house for females 13 to 18, they're all DCYF involved. And so more often than not, they do not have a caregiver who participates, excuse me, with them in the treatment. And so that's one way in which we have kind of tweaked the bigger model in order to address who it is that we were trying to work with. And then I put payment here because I wasn't quite sure how else to kind of generally label it. We, as part of Bradley, as part of Lifespan, have contracts with kind of all of the insurance plans you would expect. And because Mindful Teen is a unusual, I think an unusual is probably a fair way to say this, but it's an unusual outpatient program in that it's really offering multiple types of services. And I think the kicker that makes it hard for us to kind of charge in a more standard practice is the 24/7 phone coaching, because clinicians are truly on call all the time for their patients. And so we have contracts, special contracts in place with payers like Blue Cross of Rhode Island, with Tufts, and we don't necessarily have them in place for all the other companies. And so we're working with contracting and finances and all of that to make sure we can try to keep that ball rolling, because ideally I would like to have a contract with all of the prominent insurance companies so that we don't have to turn someone away because of the coverage that they have. And I mentioned earlier that, you know, my kind of driving force with the Mindful Teen program, whether it's clinically or research-wise, is to make sure we're doing what's best for these teens and for their families, and to help them truly end the suffering that they've had up to the point where they were seeking services with us. And so we, as part of the program, have a clinical outcomes database that we're maintaining, and we collect measures, kind of a mesh of measures from parents and from teens, as well as some clinician administered or collected data at 3 different time points right now. So we're doing pre-treatment right before they start the 18-week group. We have a second set that we're considering post-treatment at the end of that multifamily skills group, and then we contact them 6 months following that. And we have a range of measures that we're looking at, whether it's symptom specific, so depression and anxiety, specific symptoms. We're also looking kind of more broadly at difficulties with emotion regulation, the types of coping that they're using, the coping mechanisms that they're endorsing. And so this is just to give a little bit of an overview. We have been able to look at some of the data so far. And so if we're just talking about pre and post treatment, so right before starting the group and right after, we're able to show similar types of improvements compared to a lot of the other literature that's out there with DBT and DBTA specific. So we're seeing significantly decreased depressive symptoms, decreased borderline personality disorder symptoms, improved emotion regulation, increased DBT skills use, which we would imagine, and reduced dysfunctional coping. What we don't see, and this is somewhat similar to other studies, we don't see a significant reduction in anxiety. Even though, as I mentioned at the very beginning, we're seeing a lot of anxiety, and I think we see the trend towards reduction in symptoms, and it's not fully there. And maybe that'll change over time as our sample grows, and perhaps not, which at that point I think we'll need to figure out how else we can address it, because the anxiety is for sure there. All right. This part, I think, was useful for me to sit down with and look at. So I wanted to share these are some of the data points that we as individual clinicians collect for our patients. each week. So let me start by saying at the very initial evaluation, the assessment, we collect information about how many days in the past year they've spent inpatient. How many days did they, or how many visits did they make to the emergency room for psychiatric concerns? How many suicide attempts did they make? How many episodes of non-suicidal self-injury did they engage in? So we do that at the very beginning, and then we collect that same information week by week by week while the patient is in the program. And so we're able to kind of look at the 6 months while they're actively in treatment and also compare it, even though we have data for the past 12 months. This is looking at, okay, so over the past year or so, what did that look like, and did it change? So we definitely saw that 18 out of 36 of the teens that we had been working with had at least one suicide attempt in the prior 12 months to starting our program. 14, while in the treatment program, did not make any additional attempts, so 78%. While 27 out of 33 teens had engaged in cutting during the past year prior to starting the treatment, 13 were able to completely eliminate cutting while actively in the treatment. That's about 48%. And while that doesn't represent the numbers of kids who also went from really cutting frequently to just reducing the frequency in which, so this is true elimination of cutting behavior. 27 out of 34 teens had at least one ED visit for suicidal behavior in the past year or other mental health issues, and that dropped down to 20 teens. And they were having 0 visits. Again, that doesn't represent the number of kids who their frequency might have reduced. We were able to also see a pretty notable reduction in the number of days spent inpatient. Our goal is truly to keep them as an outpatient, living their life, engaged with their families, engaged with their peers, with their schools, so that they can truly practice the skills that we're providing them, as opposed to being in a higher level of care, because those contexts and environments are not necessarily the ideal in which to practice skills generalization. And then we just started playing around with the 6-month follow-up data, and we're seeing a pretty similar pattern where we're seeing the same symptoms decreasing or increasing, depending on what we're talking about, over time, and they're maintaining them, which I think is even more important, because oftentimes once a teen leaves us upon their graduation from the Mindful Teen group specifically, they will oftentimes return to their previous therapist for individual therapy. So once a lot of folks are done with us, they're truly done with us, and so to see the gains being maintained over time is really important. All right, so then just to put this out there, thinking about where we're going to go moving forward, we are currently looking for clinicians to join the team. What that means is that they would be provided with intensive training in DBT. So oftentimes, they're joining a team in which we've already been intensively trained, and so that person joining us would be sent to a formal training in order to kind of catch up. And there's a lot of consultation and supervision with others on the team to help support that person as they kind of grow their expertise. Once we're able to get a bigger team on board, I really want to focus on getting a second multifamily skills group. Our wait list is and has chronically been quite long, and it is because we are only able to take so many teens into the program formally at a time. The one group that we have running currently for outpatients caps off at 6 families at a time. So it's an open group, meaning that not everybody is joining at the same time. And so we have folks at different points in their treatment, but at any given time, the max that we have is 6 families. And so that's just, it's not enough of a resource. It's something, and it's not enough for our community. I'd really like to add in, we had added in, but had to pull back just due to coverage, clinician coverage, what's considered a graduate group for our teens, and then eventually for our parents. But this is more of a place where the teens can move beyond their initial multifamily skills training and have a place in which they're working with other teens who have completed and graduated from the program to revamp and revisit and revise their way of practicing the skills and truly just living them day to day and providing each other with support in that sense. And then, of course, as I just mentioned a little bit ago, that insurance contracting is oftentimes at the forefront of my brain, trying to figure out how we're going to get coverage for all of the families that are requesting services. And then research-wise, I think there's a ton that we can do, but certainly looking at the parent outcomes that we're collecting currently. I'd love to get something up and running with the Compass program. We're clinically partnered with them, and their involvement with DCYF has kind of left me scratching my head at times in terms of figuring out how to get the research piece truly moving. And then we're currently actually writing up one of our first papers, so it's exciting to think about sharing it with everyone else in the field so that they can kind of consolidate it with whatever else we all already know about DBT. And then, of course, if there's any folks who want to either learn more about or access services with Mindful Teen, there's a number here in which you can call. And I think I just wanted to make sure I had time, so that's all I have for now. But if there are any other questions or thoughts, I'm happy to discuss.
Thank you very much, Carrie. Very eye-opening information, that's for sure. Does anyone listening in have any questions for Carrie or any additional questions? It's a lot of information to absorb, and it's good to know that we have this service available to us to utilize as needed. So if we don't have any other questions, I would like to remind everybody that I will be sending out an evaluation of our program today. And next week, our topic will be on how housing improves health outcomes, which I think everyone will find interesting as well. So I want to extend my great thanks to Dr. Kim for presenting today. And I will have a recording of the program afterwards if you'd like to get a copy of it, or at least then we'll have your slides, which has been very helpful too. So thank you so much for presenting today, and thank you everyone for attending. Take care.
Thank you. Thank you. Take care, everyone.